Dose matters about what we do.
Poison is in the dose. If we do too much too soon, we're going to have a flare-up. More often than not, our bodies aren't ready. The demand of the task exceeded our capacity. So we've got to try to find the balance in that and bring that progress forward. I do not use ultrasound anymore. I don't think the research is great on it in terms of like the depth of penetration.
Correct that because I've been in school.
Yeah. Recently,
there's not
no
research
good research
to support it.
Yeah, there's different things that are way more effective
those
than
crystals
ultrasound,
are pretty magical though.
It's vital. It really is. I mean, finding the right amount to not set somebody back, but also to not underdose them either to where they're not progressing or they just feel plateaued or they end up feeling like PT didn't work.
Today I have with me Scott Ma, one of the best PTs in our industry. This therapist, he's a doctor, or do you have a doctorate?
I'm old school. I'm a master of PT.
He's a master of PT. I love that. But he is a PT in our community that specializes in running, in shoulder, knee, ankle. He's been doing it for 24 years, so bringing in a lot of expertise, but so excited to have him on the podcast. Welcome, Scott.
Yeah, thanks for having me. This is fun.
Yeah, I'm excited to dive into our topic. The topic today that we're discussing is dosage. Dose matters about what we do. What I mean by dose is I'm going to tell a story because, I've had physicians every once in a while come to me and ask me, can you provide for me some handouts for my patients for low back pain, just acute low back pain? And in my mind, I always think like, can I take your glasses and they work for me? Right. And not too many people think that PT is so customized like that, but
right.
It really is. Right.
Right.
So that's what we mean by dosage. Like the treatments that we provide for our patients, they have to be customized because every back pain is different. And we get a lot of flack in the community because, physicians are like, well, the biggest complaint that we have about physical therapy is that you'll go to one clinic and get one thing and then go to another clinic and get something completely different. Why do you think that is?
Yeah, that's a great question. I think PT mindset has a lot to do with that too. I've seen big changes in PT over these last 24 years. When I first got out of school, there were still a lot of modality-driven clinics where...
What do you mean by modalities?
So lots of passive things, heat, ultrasound. I haven't done an ultrasound in probably 15 years.
The PT clinic I worked at when I was young...
Yeah.
We would do 15 minutes of electrical stim. Yeah. We do 15 minutes massage and 5 to 7 minutes of ultrasound for every single patient. And then you get about 10 minutes of treatment from a therapist. And that was just standard.
Isn't that crazy? Like by today's standards, that's so outdated, right? So in the past. So yeah, you see maybe some therapists who still maybe live in that mindset where they might have their patients come in and do a lot of passive things.
Masters PTs?
Maybe even older than that.
Bachelors. Okay.
But nowadays we see a lot of...
We should call you Master Ma.
I think that's probably appropriate.
Okay.
Yeah, thanks. I think nowadays you see a lot of people who are very much more exercise driven. We've talked about loading tissue together before and how that mindset is so important in helping people adapt and progress and get past.
Give me an example of loading tissue. What does that mean?
So exercise, like you've talked a lot about deadlifts and, we had a big discussion on the deadlift dilemma, right? Mm-hmm. Deadlifting is an amazingly good exercise. We can load tissue in a way that helps it become more resilient, more robust.
Whether that's ligament or muscle or tendon.
Yeah. And that creates longevity and, more tolerance of physical daily activities.
Yeah.
So I think that mindset is great, but you'll see the old school mindset still sometimes out there too. So yeah, doctors are going to hear that patients get different things. So
yeah, it's really interesting. In school, we talk about this pendulum that swings, and you have like the passive modalities over here, which is like, massage, ultrasound, electrical stimulation, like all these feel good things. Mm-hmm. And, depending on how old you are in therapy is how you've been trained. But we have this pendulum swing, early 80s maybe, where we focused a lot on the feel good. And then all of a sudden we overcorrect. This is my population of therapists that are like way overcorrecting. And they're like, no, just load everyone.
Yeah.
Heavy weights, like that's
Right.
the way. And they forget to do the feel good along the way. So then they're just like over prescribing exercise to
Sure.
patients and maybe hurting them, and they're leaving therapy because they're not feeling good along the way.
Yeah.
But ultimately it's about the balance.
Sure.
We got to know the difference. The pendulum can't swing so far.
There's lots of tools in the toolbox, right? And some of that is needed to get pain down so that we can then use the exercise and do the load that is going to be the long-term solution to a lot of problems.
Yeah, talk to me about the tools that you use in the clinic. Let's just go through maybe 5 or 10 tools that you use specifically, and we'll dive into dosage more. But what are some tools that you use to, we use the term modulate people's pain or decrease their pain. What are some of those tools you use?
Some of those are those old school modalities, like electric stimulation, for example, can provide a stimulus to your brain to override sensation of pain, calm down. I talk to patients a lot about turning the volume down on pain. Not that these things are cures and that they're going to make your pain completely go away, but if we can minimize the intensity of that signal, then you're going to be more comfortable doing exercise and doing the tissue loading things that we want you to do.
Yeah.
So that's a good one. I got trained on instrument-assisted soft tissue mobilization in the past. And
A-stem or scraping.
Correct, yeah.
There's a lot of different names for it.
Yeah, they told us never to call it scraping because that was going to scare people, but that's only what people call it nowadays.
Yeah.
So anyway.
In society, like there's so many different street names for it. In the clinical world, we call it A-stem or IA-stem.
I think when I was trained in that, there was a lot of discussion about, we're going to use this to get down and break up little bits of scar tissue that have formed in your chronic tendon problem. But over time, I've kind of felt like, I've seen dissections of scar tissue that break the scalpel. Sometimes it's not like we're going to get from the outside in, or we're going to really break that down. But we are going to stimulate some blood flow to that area. We're going to give a neurological input to the brain, some different sensation to perceive. So that can be definitely a mellow or outer
it's
pain.
Sensitive tissue that you're desensitizing.
Right. Exactly. Yeah, that's a good word, desensitization. So
I love that. What other tools?
Even active movement can be a good thing. I start pretty much every one of my patients with some kind of an active warm-up, if they're able.
Yeah.
There's certain circumstances where I might want to heat up a joint and it's not appropriate to get it moving quite yet. They're really soon after surgery
maybe
or something.
You throw like a moist heat
So I might do
pack
some moist heat on there or something like that.
Why is moist better than dry?
It's more comfortable, I think. And there's a deeper sensation of that heat in the patients.
It penetrates so much deeper into the tissue too.
But I do like an active warm-up. I'll use a bike. I'll use a treadmill. I'll use an upper extremity, like a arm bike for shoulder and postural patients.
Yeah. Why is that important?
Getting them moving is great. Like we need to get away from constant positioning in certain ways.
Yeah.
And we'll talk more later about some examples of particular clients we've seen, I'm sure, but I've seen people who are just stuck in one position for so long, and to get them moving and changing that position and posture can be just an excellent source of
because usually pain creates muscle inhibition, and then they don't want to move because it's painful.
So
but ultimately, they need to move in order to feel better, right? Because you're getting blood flow. And I explain to patients is, you're getting food to the painful spot, right? You're gonna, not that you're feeding the pain, you're actually feeding the ability for your body to repair and heal.
Absolutely.
Right. But if you don't get the blood flow there, or, if it's a joint, getting that lubrication through those joints, then how is it supposed to actually heal?
100%.
And then all your muscles tighten up around it. But getting that active movement, so helpful.
Yeah, very, very helpful.
What other modalities do you have? Let's talk about, what if we got dry needling, ice. Do we use ultrasound much anymore? If not, why not? And then any other tools you use too?
I do not use ultrasound anymore. I don't think the research is great on it. In terms of like the depth of penetration.
Correct that because I've been in school.
Yeah. Recently,
there's not
no
research
good research
to support it.
Yeah. I think the depth of penetration.
And just so everyone knows, we're talking about a wand. It's ultrasound that's produce little signals that essentially create heat, little crystals that are rubbed together that penetrate a certain level into your tissues. And I will say there's a very small percentage that do help based on the research, but 95% of injuries, it's literally placebo.
Sure.
And it does help those small amount of patients. I actually fought this for a really long time in one of my clinics I worked at. And I couldn't get this, what was it? I think it was like a lateral elbow pain or something. And I had tried every treatment and and I was really good at treating the elbow. But then one of my therapists, I was gone, and we had an ultrasound machine we'd never used before. And he's like, let's try some ultrasound. And literally, she got better. Yeah. And I was like, no.
Of course. Yeah, I think...
But there is a very small percentage.
For sure. I just don't think of any patients right offhand who've ever told me that, like, oh, that heat from that ultrasound felt way better than that hot pack.
For sure.
I think in terms of perception, there's different things that are way more effective than ultrasound.
Those crystals are pretty magical, though.
I've seen hand therapists use ultrasound on very small ligaments in a finger or something like that, where they can focus that heat. So it might be effective, but
helpful for that.
I'm not seeing that kind of stuff in my practice. So
so if you're at a PT clinic and you're getting an ultrasound every single time, maybe
you should ask some questions. Yes,
I love it. Tell me about dry needling and what you're doing with dry needling in your clinics.
So I'm still kind of old school. I have not done dry needling as a certification, but we use it in our clinic all the time. We have therapists who are. So when I want that done on one of my patients, I just grab one of my colleagues to do it.
Yeah, because it takes an additional certification to do it.
Right.
And it's a valuable tool. A lot of our new grads, as they come onto our company, I usually will kind of hold them back a little bit and just tell them these tools are really helpful for you later. Mm-hmm. But if you can let me mentor you, I can help you create a better plan that will get you foundational principles. You have to know how to unload a tendon.
Yeah.
You have to know how to load a tendon. You have to know how to brace appropriately or tape appropriately. You got to learn these like foundational skills first. No pun intended.
Right.
Like literally learn the foundation, and then let's get these extra cool tools on top of it.
No, I think that's true.
And dry needling, right? Because they rely too much on those tools initially and don't use the clinical skills that they have to unload or load. You
hit it on the head. We were talking just the other day about a modality that often becomes used when you don't know what else to do. Maybe that was the ultrasound in that case with that friend. We use shockwave therapy in our clinic pretty regularly.
Tell me about that.
It's been very common in Europe for a long time, maybe less common in the US. But we have an applicator that kind of looks like the barrel of a gun, and there's a little piece of metal that's driven back and forth. And as it hits the metal end of the head, it creates a sound wave that then is propagated into the tissue, creates heat. I always tell patients it brings on a little bit of micro irritation too. We want the body to sense that something is going on so that it'll jumpstart that healing process.
Awesome.
So we use it on...
Explain what that's like. So say it's like on a knee.
Yeah. So tendinopathy in the patella, really commonplace. We do that. So you put some ultrasound gel on as a conducting medium, and then that applicator just kind of sits in that position.
And you just hold it there?
On most of them, yes. If you're using shockwave through bigger, bulkier muscle groups, you'll move the head around a little bit more. But if you want to really isolate it on a Achilles insertion or patellar tendon insertion, the head just stays right where you place it.
That's
and
awesome.
you can alter the frequency and the intensity.
What do people expect? Like it should irritate it a little bit. It's not painful, but
even sometimes it's painful. And we tell patients it should be a good 5, 6 out of 10 on a pain scale.
Yeah.
And if it's not, you're probably not hitting it hard enough. So we find that
so
place where they can manage.
We actually want to go into a little pain.
Absolutely. Yeah. In the Achilles as well. Different tendons.
Do you have them do exercises while you're doing the shockwave? Or
not
just
concurrently,
passive?
But again, shockwave's one of those tools in the toolbox.
Yeah.
We cause some change in the tissue, and then have that be kind of the jump start to us going into the exercise thereafter.
So
we'll use a lot of isometric and eccentric exercises on top of that kind of stuff to help load that tendon, progress it back to normal concentric use.
Yeah. So, tell me about what the research says about shockwave therapy.
There's good research for it.
And also like your clinical expertise, like how have you seen it be beneficial for patients in the clinic?
Yeah. You'll always find some people who will say, oh, there's no research on that. It's kind of garbage. But I think over time, you've seen it used in a lot of clinics.
They've been done on rats or something like that.
Exactly.
It doesn't
true.
translate to humans.
Who's the research on, right? Yeah. And I know a lot of it ends up being anecdotal, but anecdotal can be important too. Mm-hmm. And we see it. Chattanooga is the brand that we use, and they've got a lot of great research on these different tendinopathies and how people are responding, and we're seeing it. So
how many sessions do you see if someone has like patellar, let's just say tendinitis, mm-hmm. or what do you treat more, tendinopathy or tendinitis with
probably more tendinopathy. When people get
tendinopathy is really it's defined as, more than 3 months of
kind of
pain.
chronic. It
more
started
condition.
started tendonitis and then turned into this chronic tendon condition.
Yeah, and typically, so we're talking about the patellar tendon. It's underneath the kneecap. It's this tendon here. But if you've had pain there chronically, we call it a tendinopathy. So you use it for those cases.
I think we get those more often because a lot of times when people get an initial flare-up, they think it's going to go away. And then they mess around with whatever to try to get it to mellow out. And then when it doesn't, that's when they end up in their doctor's office and then
It's so
to
much
the
harder
PT
to treat
thereafter.
once it's chronic.
It's harder, yeah, for sure. So I think shockwave's been a good tool to use in that case.
Yeah, doing like some test retests, say you did an exercise that was painful, and then you did the treatment with shockwave, do you typically see like a change pretty quickly? Or, obviously you have a combination of treatments from the whole session, but do you see that happen faster?
Well, it's kind of cool when you're administering it. It'll often be a little irritable. Like I said, we want it to be a little irritable. But as the treatment progresses, it does anesthetize a little bit. You'll feel like, oh, okay, that's not quite as sharp as it was, and it's starting to mellow out a little bit. So you'll see it during application, which is pretty cool.
Yeah.
So
jumping back to dry needling, just so everyone knows what dry needling is, there's the Chinese model, which is acupuncture, using meridians and energy flow and qi. And then there's the Western model, which we call dry needling. And it's where we use little acupuncture needles. So it's a shared procedure between acupuncturists and physical therapists.
Right.
And I believe athletic trainers and some nurse practitioners and doctors can do it as well. But we target the specific tissue. So if there's an irritated spot in your low back in the muscle, we're putting the needles directly into that irritated spot, with the full intention to get more blood flow, to create improved repair at that tissue, to desensitize some of the signals to your brain. And then we can also hook up electrical stimulation to it as well.
Yeah, I've definitely had it done on myself, and I like it. I think it's a great modality. It's a great way to get some tissue to relax.
Yeah,
I love having it in the clinic, even though I haven't done the coursework on it. But having it in the clinic is fantastic.
My wife loves dry needling.
Oh yeah,
but she hates it. Every time she asks me to do it, she'll get some of this like pezanserine bursitis on her knee, and just kind of like some pain right here, and she's had it off and on. It'll flare up, and we work on it a little bit, but she doesn't go through like the formal PT stuff to fix it. But she just wants me to dry needle every once in a while. But then I go to do it, and she's like, "No, stop!" And we have to talk her off a cliff every time we do it. But
that's funny.
She's a good sport because she lets me do it, but she gets so nervous every time I do it.
I had a very similar.
I think probably it's because I practiced on her for the first time, and I've done it a couple thousand times now, but she's
been stuck a lot.
Yeah. She's traumatized by me needling her for the first time,
I had a similar experience with my daughter with using the scraping tools.
Yeah.
She basically had every single emotion you could ever imagine. She was crying, she was laughing, she was sweaty.
Oh, good.
It was a hilarious experience on my part. She didn't love it at all. So kind of funny.
So now that we've kind of talked about these passive treatments, there's so many philosophies on when to use them, when not to use them, and how much to use them, how frequent, how long, how intense, all the above, right? Yeah. But now kind of diving into the really deep portion of this podcast, what does it mean to appropriately dose exercise? Because some people, will come in, I have this population with Ehlers-Danlos syndrome.
Oh, yeah.
Right? Hypermobility. And I'll do just very, very simple exercises, and it will just flare them up.
It's wild, huh?
And it will just put them in bed for a whole day. That is a tricky one. Right? And I always will educate the patient and say, my job is to appropriately dose your movement. Mm-hmm. I don't know how you're going to respond. I've taken in your history, so I understand what you're doing.
Right.
But with these particular patients, I tell them, I don't know how you're going to respond from these 3 little movements today.
Things that you wouldn't expect would flare somebody up on a generalized
I had a patient
basis.
just 2 weeks ago. I start doing little, cat camels, just kind of, or cat cow moving through their upper back and moving their neck just a little bit. It literally put her in bed.
Wow.
For almost 2 days.
Yeah, that's not what you would expect.
And I'm really good at treating that population, but we have to customize it to the individual needs of the patient.
Sure.
But I warned her beforehand. I said, this is what to expect. We could have an increase, but I want to follow you up with you at the end of the night today.
Yeah.
And I typically don't do this with my patients, but for her in particular, I'm like, I'm going to follow up with you today, and I'll follow up with you tomorrow.
Yeah.
And I had that conversation, and then the patient's mom called in and says, we're not doing therapy
She's
again.
not coming.
We're done.
It's
And
hard.
I even warned her, like,
Yeah.
and they were so excited to go through the PT experience and progress through that, because I've treated thousands of patients with EDS, and, but I warned her, and, I pushed it just a little too much. And it's hard because
you don't often know what that too much is going to be, at least in the beginning. I think we are often trying to figure out the right dosage for each people.
Like what do you do what are you asking in the history to help you determine of where to start?
Yeah. A lot might be intensity of discomfort, the length of time they've been dealing with it, what they've done about it in the past, and how they've responded to that kind of thing. That gives me an idea of maybe where to start. I had a very similar example just last week. I had a patient come in with some plantar fasciitis, so pain in her bottom of her foot. It wasn't the classic where you have pain in the heel. She had more pain in her arch, and it wasn't really high. It was probably, a good 3 out of 10 on the pain scale. Uncomfortable, but not the worst by any means. And I taught her some heel raises to kind of load the bottom of the foot, and a way to stretch the plantar fascia with a little simultaneous self-massage.
Yeah.
And same experience. Next thing I knew, she had canceled her visits, and I was like, whoa, what happened? So I reached out, and she just said, I just had a really bad response, and I don't want to risk having that again. And I said, well, that's exactly the feedback we need. We can easily dial these things down a little bit more, but if they don't know right off the get-go that that's kind of our MO, we're gonna figure out what you can tolerate and then how to adapt that. Then
and these
it can be hard for them
conversations
to
are
want to
so
continue.
important, but sometimes they still don't go anywhere, right?
Yeah.
But ultimately, they're in the right place, right? Therapy is going to help them, but it's our clinical expertise, what the research says, and what we're hearing from the patients that has to guide our decision making. Right. If we make the wrong call, it's like a bad play.
It can be.
But does that mean the coach just throws in the towel and we're done?
No.
Like just bag the game because we had one bad play.
Right.
But
there's some
we
regrouping.
come back.
Yep.
We huddle up and we say, okay, what is it we learned from this experience? And then we're going to make some changes. We're going to call a different play next time.
Right.
But if we don't have that feedback, we can't change anything.
Right.
And we need that. You need to go through a good 4 weeks of therapy to see if it's appropriate for you, because you should see a change within that time, but we should be able to dial in our craft by then.
For sure. I hope patients know right from the get-go that we're a team, right? Just, I love the analogy of a coach there, but we're a team. We need to communicate on those things, and we'll find that right sweet spot. And hopefully we don't overdo it right in the beginning. That doesn't happen very often, but if we can find that right level of load and gently progress that over time, people get to be really happy.
The hardest ones are the ones that, I'd say the majority of the patients feel their pain now, right? It's like, okay, it's feeling better right now, or it's feeling worse right now. And in session, it's easy to measure. The ones that are hard, it's like, well, they're feeling good the whole time. And then tomorrow they're just like completely, bed rest.
Yeah.
Like they just cannot get up.
Right.
Those are hard to measure, but those are the ones that we really need feedback on how to progress.
100%. I'm treating a lady right now with a chronic hamstring strain, and while we're doing stuff, she feels fantastic. And then 4 hours later, her discomfort starts to set in. It's just a little bit of a hard thing. And then when you maybe get them in the clinic and you're trying to replicate some of their symptoms by our testing and measuring and whatnot, and it's not there, that gets a little harder. They have to go and do stuff and then get it a little bit flared up, but that will help us answer some more questions. So
why can someone not just like YouTube or Google some exercises that are going to help their and I actually had a patient come in the other day. We'll come back to that question because this relates to it, but I had a patient the other day that says, I love my physician. He has a whole stack of every injury that you could ever have. And he says, here's the PT for your condition. Tell me how you feel about that.
That's kind of brutal.
Me cringe. I was like, no.
Yeah, no, I'm
a handout.
I'm
Perfect.
right with you. Yeah. Handouts can have great things on them.
It replaces my job. Good, thank you.
There's great things on handouts. Let's not, we could be honest. That being said, every person is so different that they may not be ready for that kind of stuff.
Why does one handout for patellar tendonitis not help for the next person?
Yeah.
Why is that? Why can that be not helpful?
Everybody comes from a different level. We mentioned it a little bit ago. Like, you may have somebody who's literally done nothing for a long time, and then they buy an exercise program off of Instagram because they see how cool it looks. And the next thing they know, they've done too much too soon after a period of doing too little for too long.
And then all of a sudden PT
they're
didn't
there.
work, right?
Right. Whether that be the Instagram program or the handout from the doctor.
Yeah.
So I think we have a great opportunity to find out where people are and figure out where they're starting from. And then we can kind of build them from there.
Yeah.
So that's why I think handouts are not the best. They need to be more individualized.
Yeah. Like, could you imagine, like, we just have a bunch of glasses on the wall. It's like, yeah, go pick your glasses. Yeah. That's the one for you.
Yeah.
You know, like this, here's the patellar tendon up, or here's the nystagmatism section. You know what I mean? Like, or like with dosage with medication too. Right. Like, could you imagine your doctor prescribes you a dosage of medication that he prescribed to the last person?
Yeah.
Do we do that? You know, and it's so hard for physicians to dial in the dosage. It's the exact same principle with what we do.
Right.
Ours just happens to be movement dosage.
Right.
Theirs is medication dosage.
Sure.
But you have to consistently go back and report on how you felt to be able to get the appropriate dosage.
Yeah.
And same thing in therapy. We need those reported feedbacks because we're going to adjust it and customize it based on what you're feeling.
In therapy a lot, you and I have talked about this. I use the phrase with my patients, the poison is in the dose, right? So if we do, again, too much too soon, we're going to have a flare up, you know, more often than not. Our bodies aren't ready. The demand of the task exceeded our capacity. So we've got to try to find the balance in that and then bring that progress forward. So
yeah, I totally agree. It's so challenging to appropriately dose, but once the therapist knows the patient and they know how their body responds, it's fairly simple to go through that progression.
Very much so.
And that's why you can't really YouTube a bunch of things, because you don't realize that doing one exercise to the next exercise just skipped 4 steps.
That's right.
You literally, the amount of load that's through your Achilles tendon, your heel cord, you literally just skipped 4 steps.
Right.
And then all of a sudden you skip that 4th step and it hurts. And then you think, oh, it didn't work now.
Right.
It wasn't because you did exercises wrong. It's because you skipped 4 steps.
Yeah. Yep.
It's literally you taking a baby from laying on its back to now running. Like, that ain't going to work.
That's
you got to develop foundational skills to build up to that,
yeah,
right?
For sure.
And when people get these handouts or YouTube or whatever, they think that PT didn't work. PT is not a handout.
Right.
Right? PT is not exercise. PT is doing physical therapy with a skilled clinician.
Yeah.
Right?
It's super multifactorial.
Like, sometimes it frustrates me when chiropractors in their offices will, I love chiropractors. I use
we work with a lot of really good ones. Yeah, absolutely.
But when they advertise that they do physical therapy in their clinics, ultimately, physical therapy is with a physical therapist.
Right. No, I agree with that.
Right. So it can kind of confuse people. And when they go talk to their surgeon, they say, hey, have you done physical therapy? And they're like, oh, yeah, I did it.
Yeah. I had some heat, some e-stim, some ultrasound.
Yeah, some passive modalities.
Exactly.
That's not physical therapy.
No.
Physical therapy is with a physical therapist that can guide the dosage.
Absolutely.
You know, and it's such an important skill that we've developed. It cannot be replaced by AI or YouTube videos or any handout, because it's so specific to what you do and how you respond to it.
Right. Yeah.
Let's talk about protocols for a minute. You know, so say someone gets a surgery and there's a protocol. Tell us what a protocol is.
So a protocol would be the standard method of progression through the rehab, from kind of an acute postoperative phase through a final return to activity phase. We see them all the time. Every doctor has them, and they're often very, what's the word I want to say? They're principles. They're frameworks. Yes, that's a great word. So a framework for how to get from point A to point B. It's interesting when I get to collaborate with a doctor on creation of a protocol. It's awesome. I mean, there's connection there. There's an understanding on the doctor's part of what we're doing. So when I worked up in Washington State for a number of years, it was very common for me to get a postoperative rotator cuff shoulder surgery patient 6 weeks after surgery. They've been in a sling for the full 6 weeks, not moving at all. And that was part of the protocol.
Yeah.
They would come and I would evaluate them, and they would be super stiff, and I knew we would be working together for quite some time going forward.
Yeah.
And there's lots of great research that shows that early motion is good. So when I've been able to collaborate with docs on getting their patients in a little bit sooner, showing them the benefits of early movement, it's been awesome. And it's not like we're doing crazy motion right at the beginning. Some of it's baby steps, but it is mobility that's super important. And it minimizes the chance of them getting stiff and frozen and things like that. So
yeah, absolutely. I mean, ultimately, I think that the protocols were created because physical therapists had an associate's degree, and the surgeons and these physicians, it was their job to run the rehab.
Right.
So they created these protocols to create this framework for therapists because they were not independent, autonomous thinkers. Right. But then we went from an associate's to a bachelor's to a master's and then a doctoral degree.
Level now, yeah.
And the intention behind that training is to take a load off of these physicians. So a lot of these protocols are not even research driven.
Right.
They're just based on, a surgeon's preference rather than actually what the research says. So a lot of them are outdated.
Yeah.
We need to get therapists in there to help with that recreation that supports the literature, but also supports clinical expertise, but then creates improved frameworks so that way therapists can then customize it to the individual patient.
Yeah, 100%.
What are your thoughts on that?
No, I think that's great. Ultimately, that's what we want. We want the patient to understand there's great principles to guide their rehab, but again, they need to be individualized to them based on where they're starting and where they want to get to. And then we can kind of work with the physician and let them know, hey, we're on this. We know what's happening. Yeah. We're going to guide them, and we're going to keep you updated. We're going to keep you in the collaboration. It's a great team effort between patient, therapist, and physician. And if we're all working together on that, that ensures better outcomes in most cases, I think. Yeah,
absolutely. And I think a lot of the reason why they were created in the first place is we could have potentially hurt a lot of people, right? So they repaired something. It's like, I just spent a lot of time repairing this rotator cuff. I don't want you to mess
Certainly
it up,
don't move that too quick or whatever.
And maybe the therapist did and tore it and they had to go redo it, right? So then they kind of created this protection barrier to make sure that they didn't have to do that, or there was no sort of legal things that happen along the way.
Yeah, makes sense.
Right? But ultimately, we were going into a revolution of change. And we need to get to the point where the doctors of physical therapy are running rehab and collaborating so well with the surgeons that the surgeons respect the protocols that we bring to the table.
Yeah.
And we show them this is what is going to get you the best outcome. Are you feeling comfortable with this? And that conversation has to start. You kind of have had some of these conversations. Tell me about your conversations that you've had with surgeons and how they've been beneficial and what you've done to navigate through all that.
I think the big one I mentioned is just in terms of early motion. I think that's been vital.
How'd you start these conversations with some of the surgeons you've worked with?
Yeah, and that can be a little scary for a therapist at times too, because these docs have been doing this for a long time, perhaps.
Been doing this for 25 years. What do you got to tell me, young
Exactly.
buck?
They're accustomed to their ways. It's great to show them positive outcomes that come from doing these things. You can relate experience of patients, hopefully their patients who did really well. Not that we've violated their protocol to help them get better, but within that principled framework, I can just show them, hey, this is how we approach this, and this person did amazing.
Decrease their fear.
Decrease fear of us screwing up their surgery, so to speak. Yeah. I think all of the therapists are very, very conscious of that. That's not something that we want to do. Relationships with the physician and the patient are super important. So we're going to be pretty conservative, but within the framework, we know which direction we can take. And
what advice would you have to a therapist that is a little afraid to approach, a surgeon about this? What advice would you give for them?
Great question. I think the physicians want that discussion. Yeah. When I was a very young therapist, I don't think that was the case. Things have changed a little bit now. I think the education.
And I would say a lot. We have a lot of groups that they want it. They want the help, right? They're relying on us to tell them what should we do.
And the education, the training that therapists are getting nowadays is pretty high level. It's pretty amazing. I see a lot of difference from when I came out of school. I think they're way more prepared than I was. They have the makeup, so to speak, to go to that physician and then be able to say, look, this is what I've seen. This is what I know. I'm anxious to work with this person. Let's collab together on this.
So be confident in what you know.
Absolutely.
I'm surprised how in-depth knowledge that we have, but the lack of confidence that we have.
Right.
Like when I have therapists go to present to surgeons at like a rounds presentation, those surgeons spend the majority of their time mastering the craft of a surgery.
Right.
They don't spend time in the rehab world.
Right.
Right. They get bits of it. But when you're speaking to them, a lot of them don't know the majority of what you're talking about. And they appreciate that you're breaking down in layman terms why it matters to get them moving sooner. Right. They don't really realize that, right? They don't realize how that's affecting the patient's outcomes moving forward, right? So when we explain that and really break it down for the surgeons, they're totally on board.
Totally. Yeah.
And we just essentially put up on these own walls saying, you know, they're gonna push back, right? Or they're not gonna they're gonna fire me as a therapist. It's like, no, we all need to operate independently and autonomously to use our skills that we've been trained on to get the best quality outcome for the patient.
No, 100%. And I do think more and more physicians are open to that. They wanna hear what's happening in PT, but they're sending the patient to us. You know, you're right. They master the craft of the surgery, and then we can kind of help them get to that next level thereafter. So
absolutely,
we have the skills and the knowledge to do that. So why not share and collaborate?
I love it. We'll kind of finish up as we wrap up this podcast on the dosage, you know, but why do you think it's so hard for these new graduates to appropriately dose patients?
You know, when I was a younger therapist, I can go back to some of the early clinics that I was in. The heaviest weight we had in there was like a 10-pound ankle weight.
Or some TheraBand.
Not heavy enough.
What are we using now?
Kyle, in our clinic, we've got a series of kettlebells. We've got trap bars that we're putting 45-pound plates on. We've got a barbell.
No patient with back pain should be leaving the clinic without mastering a deadlift.
I agree. And it's so
and I'm
fun.
not saying under a barbell. Like there's so many variations.
Just with like a kettlebell. Like I've had so many patients afraid to bend over, and you've got to bend over to open your oven,
blow up.
To pick up your laundry, to pick up your child. You know, that's
everyone
so
needs
important.
to be able to do a deadlift. Yeah, absolutely.
So we can scale that exercise into something really easy, and then eventually they're picking up heavy weight, and that's cool.
Yeah,
that's really fun. So having the equipment available, I think, is a big deal. If you don't have that, you don't really learn how to load progressively and appropriately. So having heavy equipment, I think, has been a really cool thing.
Yeah, there's multiple things that I think about when I'm appropriately dosing someone, right? There's intensity, there is frequency,
duration,
there's duration,
complexity,
like the complexity of movement. Maybe you're putting multiple movements together. There's just so many things to consider. And that's why you got to make a choice. Are we going to do less reps, more reps? Are we going to do more time? Like there's just so many things to consider.
Getting to know your patient and how they're going to respond to those things, I think, is vital too, because you're going to have some people who are a little more apprehensive, and then some that are a little more go-getter, and you're going to have to pull the reins on them. I can think of two cool patients, both of whom I loved. The first one was my very first patient when I started working in Utah County, and this guy was on a four-wheeler, and he was flying down this hill, and he realized at the bottom of the hill he was either going to go off a cliff edge or he was going to go into like this swamp, this bog. And he decided, you know what? I'm not going in the swamp. And he ditched the four-wheeler in the air, and he tried to start running in the air, thinking that he would continue running when he landed on the ground. It was just like something out of a cartoon. Yeah, you on your motorcycles, you've probably done this
before.
My
feet get going really fast.
So he ends up fracturing his heel on one side and fracturing his tib-fib on the other side. So he was non-weight bearing in a wheelchair when I first met him, and he was a go-getter. He was one I had to pull the reins on. In order to kind of make his recovery process follow the right timeline. We had to make sure his expectations were, look, you need to check that aggressive attitude and maybe mellow out. On the other hand, I just got done treating a lady who had a pretty standard arthroscopic meniscus surgery in her knee. So it wasn't a repair, but she comes from a pretty high fitness background. But her level of apprehension was actually pretty high. And so it took her a long time to develop tone and strength in her quad. Very, very reticent to load her knee, even on like a 6-inch step down. So less than her normal stairs at home. So it was hard. And that one took a longer time frame because of her makeup and her nature and her apprehension. So we figured that out. We worked on that together, and we tried to give her confidence, and the dosage had to follow that. And when we got that right, she did really well.
And so it's super challenging, but it's super important to communicate really well. The patient is part of the healthcare team.
100%.
And the feedback that you give your therapist is critical to your success. I just pulled all this data just barely for a keynote that I'm doing. Around 80% of all orthopedic injuries get better with therapy.
Yeah.
If you're not one of them, it may be because the dosage is wrong.
Correct.
Right? There's tools that we use to improve your pain, and there's other providers that we use to help along the way. But ultimately, 80% get better with therapy.
Yeah, that's a cool stat. That's a high number.
All orthopedic cases.
Yeah.
So it's, just knowing that number alone should help develop confidence that you're in the right spot.
Right.
And we're 3 weeks down the road. If you're not making meaningful progress, we reevaluate.
Exactly.
And we recalibrate. We know therapists should be seeing their patient for 20 visits and 0% better. That doesn't help anyone, right? You should see a natural linear progression of your improvement.
I think patients need to know that reevaluation is something we do all the time.
Mm-hmm.
We're constantly looking at the dose. We're looking at the outcome.
Mm-hmm.
We're looking at the symptoms. Are those things changing? And if they're not, we need to change direction.
Yeah,
so
and sometimes
that's
we'll
important.
increase the doses, decrease the doses, increase the intensity, decrease the intensity. There's constant recalibration with every visit.
Yeah.
And that's why you do frequent visits with a therapist.
Sure.
I love it.
And we respect healing times, right? There's certain time frames that are important for a tendon or a ligament to heal. And we got to know that. And that dosage is adjusted based on those healing times. And then we can really develop the complexity later on to be more functional, more sport specific, whatever their hobbies might be.
Yeah.
But that comes over time.
In some injuries, you actually have to push into pain. In some injuries, you don't want to touch the pain at all. Some injuries, you want to push to the pain, but not through the pain.
Right.
But how do you know that? It's some in-depth education and clinical experience that helps guide those decisions.
Yeah.
So any other concluding thoughts as we wrap up this podcast?
No, I love the concept of dosage. I think it's vital. It really is. I mean, finding the right amount to not set somebody back, that they have a flare-up or something like that, but also to not underdose them either to where they're not progressing or they just feel plateaued or they end up feeling like PT didn't work.
Yeah.
If we can get that right, people are going to see really positive things change in their lives and get back to doing some of the things that maybe their pains and discomforts are not letting them do right now.
I love it.
It's cool.
Well, thanks for joining us today,
It's been
Scott.
awesome. Thanks for
having me.
Great
discussion.
Yeah, thanks.